My name is Neeraj Jain. I'm going to talk about the lumbar Z-joint applications of the Coolief technology. A lot of the physics have already been discussed, and we can get through that relatively quickly because it's the same for lumbar. We'll talk a little bit about the anatomy, selection criteria for patients having neurotomy, and the specifics of the technique with the cooled RF. The Z-joint has been established as being the nociceptive input, or the nociceptive input for the Z-joints come from the medial branch of the dorsal rami, and we've established that. We've all done lots of medial branch blocks to prove that the pain is facetogenic in nature. The anatomy of the lumbar medial branch, as it emerges from the intervertebral foramen, the medial branch of the dorsal rami run across the respective transverse process and pierce the intertransverse ligament at the top of the transverse process. It then runs along the groove formed by the junction of the SAP and the transverse process at the base of the SAP. Hooking medially then around the base of the SAP, it is covered by the Mamillo-Accessory Ligament, which is relevant in terms of where you're going to actually do the lesion. So the MAL would cover the nerve right at this point here, and then it crosses lamina and divides into multiple branches, supplying the motor for the multifidus and interspinous muscles. It's the medial branch is very consistent L1 through L4, unlike the thoracic medial branch, and the portion of nerve that's exposed on the neck of the SAP is between the Mamillo-Accessory Ligament on the anterior aspect of the SAP. So probably a little bit more distal than what we're traditionally used to thinking about the notch or the eye of the Scotty dog, where we typically have done lesions in the past. Distal to the neck of the SAP, the medial branch disappears under the MAL. So placing a lesion in the posterior part of the SAP may not be the most efficacious way to do it. The ligament may protect the nerve from coagulation. And in fact, the ligament can ossify also, converting the notch into more of a bony foramen. This is more common at L5 and less common as we go up the lumbar spine. So again, doing the lesion a little bit distal on the neck of the SAP, somewhat anterior, may be the best place to catch a nerve. And we see that we have adequate margin of safety, 8 millimeters between the nerve root and the anterior aspect of the superior articular process. So the 8 to 6 millimeters at L1 through L4, if we're doing the lesion on the SAP, on the anterior aspect of the SAP, we should be well behind the nerve root. And there's further things with the Coolief technology that allows for that margin of safety. So the newer insights show that the L1 through L4 medial branch nerves commonly lie across the lateral aspect of the superior articular process at its neck, slightly up the SAP, not square at the junction, as we said, while some may actually still lie in the groove, but probably more likely a little bit more distal. And this isn't true for L5. We know the prevalence of Z-joint pain, as Manchikati showed, it's higher in pain clinics and higher in elderly people, but it is a fairly prevalent problem, just like the other, the SI, the thoracic, and it's something that is fairly treatable. In terms of diagnosis, the patient is, you've determined that they have chronic, unremitting or recalcitrant back pain, axial pain, and the patient's achieved a good relief following medial branch blocks, good relief by definition, 80%. And then we can further enhance our positive predictive value of the medial branch block by doing modified comparative blocks, as Dreyfus has pointed out. And that really substantially increases the positive predictive value for the medial branch, still with the fairly significant false positive rate, but that is probably the most specific, sensitive way to diagnose this. So selection criteria for the patient, it's the same list of indications, contraindications that we'd use for traditional RF. We need to know what the results of the diagnostic block are, and then obviously no other contraindication to doing the procedure. In pacemaker equipment, we have to make some modifications, any coexisting diseases, and then most importantly, the expectation of the patient. What does the patient expect from the procedure itself, and how well of an understanding do they have with it, and the true reason why you're doing it for the back pain, and it's not for leg pain or any other syndrome they have. And we know that most commonly lumbar facet pain is going to be axial paravertebral pain. Less likely it's going to radiate in the lateral or posterior thigh, and then least likely into the more distal into the foot. Of course, we need to exclude any other pain generators in doing the rhizotomy, including radicular pain, hip pain, greater trochanteric bursitis, SI pain, and this is typically how we would determine what the pain generator is. Paravertebral is much more likely than central to be facet-mediated, and it's extension-based pain. The diagnosis, the target specificity of the medial branch has been established using CT confirmation for the contrast flow of the procedure. We need good anatomic placement of the needle, and this can be proven by the flow of the contrast that we're really encompassing or targeting the medial branch without getting any adjacent neural structures that could confound the results of the medial branch block. The limitations, of course, if the medication, local anesthetic, goes intravenous, and that would be the reason for using contrast. That would obviously increase your false positive rate. So the diagnosis, we examine every patient post-procedurally, looking for 80% resolution of the pain. That's sometimes that can be difficult for the patient to describe that topographical numbness if it really correlates into pain relief for them. But I think if you take the time to examine the patient, you see that their range of motion is improved, which is typically their most painful maneuver, or have them walk or do some of the other provocative things.